Hey, and welcome to today's 5-minute physio tip. I'm David Pope from Clinical Edge, and today I'm going to be talking to you about manual therapy. How do you know if it's indicated in your patients? Last time we talked a bit about the debate about manual therapy, whether it has a role or whether we should just be performing exercises. So for more detail, you can head to that one. But today we're going to be looking at more making sure that we have got good support for the particular patient that's in front of you to actually perform manual therapy. So when you're looking at your clinical reasoning around a patient that comes in with pain, the first thing we need to do is identify from their history where their pain is, what their movements that are related to their pain and aggravate it, and whether there's any relationship between symptoms. So say for instance you've got pain in the shoulder, you've also got some pain in the neck, if there's any temporal relationship, so if they come on about the same time, or if they're separated and they feel like they're a similar problem. So if you're treating the patient's shoulder pain, they've also, when you've dug around, found out they do have a bit of neck pain or neck stiffness that comes on in a similar time frame, you've got some support to be heading over towards the neck and starting to suspect the neck. So that's our first thing. We're starting to look for indications from the history about whether there's some sort of an intermittent association between their symptoms. And we know for all physio treatment, we tend to get a much better response for intermittent issues and pain as opposed to constant pain. So we're looking for that intermittent nature, some sort of relationship between symptoms to some sort of stiffness or pain related to a spinal area, for instance. So that's our first thing. Now when you start to assess the person, what we're looking for is to identify a restricted range of movement and also something that's painful and restricted that's related to their functional issue that they've come in for. So, for instance, they might be someone that says they've got pain with right rotation of their cervical spine. So every time they're driving, they look over their right shoulder, they get this pain in the right-hand side of their neck, down low. So that's one indication, or it could be that they get pain in their lumbar spine and hip every time they bend forward. So now we're starting to go, okay, we've got an area of pain. We now go, at what range do you get your pain? So they go, when you assess them, they get their pain at, say, 45 degrees of right rotation, and that's a 3 out of 10 pain. It's the same pain that they get normally when they're driving the car. So you've got this relationship between their current pain, you've reproduced it, you've identified a range of movement objectively, and also a subjective pain level. So that is a 3 out of 10 pain at 45 degrees range of movement. So now we've got some really clear assessment, reassessment findings. We've got an intermittent mechanical nature to their pain. And now we can start to explore whether manual therapy is going to be the go-to treatment for this, or whether we need to go down another path. So there's a number of different ways you can start to identify it, but the main thing that you need to look for with any of your manual therapy techniques is that you immediately get a change in their pain, and you can use a couple of different ways. So for instance, you could use some sort of a snag, a nag, or a mobilisation with movement at a particular level that you suspect to see if you can change their pain and range of movement. Sometimes it can be a little bit difficult to try and go, well, we've got, say they've got restricted right rotation, you've got pain, you could press on anywhere between unilateral, central, and the opposite side between C1 and L5. So there's a whole bunch of different joints there. So we need to narrow it down generally a bit more before we just go, does that help? No. Does that help? No. Does that help? No. We've got to get it down a bit narrower than that. So this is where we need to start tying in some sort of other assessment like PAVM or PIVM assessment. Personally, I tend to prefer a PAVM assessment, looking for restricted ranges rather than looking for pain. So identifying a painful level, like I sort of mentioned in the first part, is not a good indication for doing manual therapy. So if we go, you've got pain in right rotation down here, we press on that level, that reproduces your pain, that's not an indication. All you've done is found, that hurts when we press on it. That doesn't mean you need to bounce up and down on that joint or do some sort of manipulation or whatever it might be. It just means they're painful at that joint. So now what you really want to be looking for is some sort of a restriction in their restriction in their passive accessory glide. We're going to talk a bit more about passive accessory glides, whether they really are a passive accessory glide or whether they're more of a physiological movement in another longer episode. But for now, we're looking for a restriction rather than pain. So first thing, we identified range of movement and pain that is the same as the person's pain. So we've got objective measures for each of those, 45 degrees, 3 out of 10. We've now done our PAVM and PIVM assessment to go, okay, we've got a restriction at C23 and on the right and T12 on the left. So you've got two levels now where you go like, oh, that was pretty interesting. We found a restriction there and a restriction down here. Where are we going to treat? Should we treat it? Is it going to help? We don't know. So that's where we can move into your snags. You might provide a glide at that level while the person's performing their right rotation to see if you can get immediately a change in their pain and range of movement or not. So that's one way. The other way is your mini treatment. So you're looking at going, let's perform. So we found restriction at that C23, mostly at C3 on the right. So we're going to, it's not painful, but it's restricted. And we've done it with quite gentle PAVMs. We've gone, okay, we're going to work on this C3 for maybe 30 seconds, up to a minute, maximum. So we haven't wasted much treatment time. We've just gone, we found a restriction on their right at that level. We believe that restriction is related to their restriction in rotation and also their pain. So now we're going to do some mobilisation and we're going to see what changes. So you do a minute of mobilisation and we're going to talk a little bit about how to be really specific with your mobilisation in future episodes and if it matters. But you found that, you mobilise it for 30 seconds to a minute, you immediately sit them up, reassess, and if they go, yeah, I get to 45 and I'm 2 out of 10, you haven't changed their objective measures and you've had a somewhat of an improvement but not a significant improvement in their pain. That's not really an indication that you're on the right level. So then you can go to the other level and go, righto, what about that T1 on the left? Let's do some mobilisation of that. We'll be really specific in how we're doing it. Now we've got a change. We're at 70 degrees rotation and we're down to a 1 out of 10 pain. So we're starting to build up some clinical reasoning. We believe their pain at C5, 6 is related to the restriction at T1 on the left. And we've got support for doing that because we've changed their pain and their range of movement in the movement that's particularly related to their pain. So we know they had pain with right rotation. Now it's much better. We've got some really good support for doing manual therapy there. So we can lie them back down, do some more PAs or APs or whatever you like to do. T1, probably not an AP, but a PA on that level and carry on with that until we can improve their pain more, until we plateau. In an irritable situation, it's important not to do too much, but you've got some support to do more manual therapy at that level. So that's some clinical reasoning, working through the cervical spine, making sure that your manual therapy is appropriate for that patient, making sure that you are having objective and subjective changes to their range of movement immediately, and that you have a within session change. And we know that from the research that within session change is really related to whether they get a change between sessions. If you can't get a change within your session, you're not going to get a change in between sessions. So get that clear picture, make sure you've got good support for your manual therapy from getting a change immediately, and then make sure you follow it up with, number one, your language, making sure you're communicating to your patient that you're just enabling them to move. You're helping those joints to move, but it's up to them to carry that on, and then you can incorporate your other exercises that you like to do after that. So that's all for our 5-minute physio tip for today. Hope you enjoyed it. Let us know in the comments below if you've got any questions, thoughts, or whatever. I look forward to reading all those. And yeah, have a great day, and I look forward to catching you on the next episode where we're going to be talking a little bit more about specific techniques that you can use and how you can apply them. See you then.